In recent days, the BBC has broadcast a new documentary in which critical aspects of Child O from the Lucy Letby case were discussed, particularly by consultant obstetrician Professor Phil Bennett. In this video, I'm going to go over the key aspects of Child O as succinctly as possible and explain every aspect of this infant. So one of the important things to note about Child O is that this was a unanimous verdict in the court case. I would suggest immediately the reason that it was a unanimous verdict was that the court heard misleading and very poor expert testimony. But nevertheless, as it stands, this was a unanimous guilty verdict, one of three in the court case. So the first part we're going to look at, part one, will be the prosecution allegations. And there are essentially two elements to the allegations that were made in court. As noted here, it was initially alleged that Child O received inflicted blunt trauma to the abdomen, causing purpuric discoloration and a ruptured subcapsular hematoma of the liver, and that air was injected into the nasogastric tube to cause gaseous distension of the intestines. Later, the accusation was changed to deliberate injection of air into circulation, one of several cases in which Evans has changed this mechanism. Now, we're going to get on to the bleeding and subcapsular hematoma aspect of this case in due course, but firstly, let's deal with the air allegations. So the first thing to say is that the two separate allegations that Dr. Evans has made that I've just listed are two very different alleged mechanisms of harm affecting different anatomical systems and producing different clinical pictures. Before we examine that any further, it must be said that the whole allegation related to the injection of air here seems completely preposterous immediately based on the clinical picture of the infant, but I'm going to get into that later in the video as well. So air injected into the nasogastric tube would result in gastrointestinal gaseous distension. A nasogastric tube goes through the nose into the stomach. If air were deliberately pushed through it, the alleged mechanism would be expansion of the stomach and intestines. Expected physiological effects from this would be gastric distension, abdominal distension. The air, of course, would travel through the nasogastric tube, through the stomach, into the bowel. So we see in the court case there is this reference to the baby having an episode of vomiting, abdominal distension, and also bradycardia. This is why Dr. Evans has plumped for his theory that air was injected via the nasogastric tube. So he also made reference to this purpuric rash on the right chest wall. There was a note from Dr. Brearey. Lucy herself also made notes in relation to this as well. So as mentioned, the new allegation that wasn't even discussed in court is a completely different mechanism. Here the allegation would be that air entered the circulatory system, for example through an intravenous line. The pathway would be IV access, bloodstream, heart, pulmonary circulation. The problem would therefore not be pressure on the abdomen, it would be air bubbles obstructing blood flow, and the presentation of this would be completely different. Now, we're basically going to ignore this to a great extent. I'm going to cover some aspects of this in the video, but I'm going to focus primarily on what was actually said in court, as opposed to what Dr. Evans has written since, or said since. So, before we get into that, I'll just go over the criteria that were used to diagnose air embolism. So Dr. Evans used the primary criteria of an infant collapsing rapidly or an infant failing to respond to resuscitation. He will then also use what can reasonably be considered the only meaningful diagnostic criterion of citing rashes, mottling or discoloration. None of this is relevant to the allegation used in court, which would have a completely different presentation had air indeed been injected via a nasogastric tube into the stomach, into the bowel region. As I've mentioned, as I've discussed ad infinitum on this channel previously, Dr. Evans' so-called diagnosis, in which he decides it's an air embolism because an infant collapses rapidly and fails to respond to resuscitation, has absolutely no scientific or medical merit whatsoever, because there are dozens of possible causes of an infant collapsing rapidly and failing to respond to resuscitation. Of course, it's also notable that in some of these cases, the collapse wasn't even rapid anyway, and the resuscitation failed because the resuscitation was, let's be generous, suboptimal. So, in the court case, or during the court case, Mr. Ben Myers made the following comment: "You have again tried to knit one piece of evidence to a mechanism to support this allegation, haven't you?" And of course, that's entirely true. One day I'll go over the cross-examination of Dr. Evans in relation to Child O. I've got all of the court transcripts in which Dr. Evans speaks, so I've read every single word that he said in court, almost every single time. Probably, it'd be fair to say, literally every single time is a complete train wreck, and this was no exception. Now, before we go into the bleeding aspect of this, the important thing to note here is that the entire air aspect, the allegations made, whatever they are, we don't even know what they are. We don't even know what he's put in his most recent post-trial report, but we know that he's abandoned the air splinting the diaphragm because it's been absolutely ridiculed by neonatologists. But regardless of which one of those two separate mechanisms Dr. Evans chooses to rely on, the air allegations, the air aspect of Child O is completely untenable. As I've said previously, both in relation to this case and other cases, particularly Child E, if this was a real-time diagnosis made by a doctor in a hospital, considering the clinical picture of Child O, the idea that it was caused by air would be deemed literally laughable. It certainly appears that the only reason the introduction of air has been mentioned in the case of Child O is that Evans has used this in other cases. It certainly doesn't fit with the clinical picture of this infant, or indeed make any sense whatsoever. So you can see here Dr. Evans talking about the air in the abdomen being excessive and could indicate air having been infused, injected in other words, into his stomach via the nasogastric tube, and this had tracked into the intestines, causing abdominal distension. That's why I'm going to focus on this air via the nasogastric tube theory. It can barely be described as a diagnosis in this video, because that's what was stated during the court case, as you see here. And then the final thing I just want to say in this first part is that Dr. Evans said the following in court: "So the bleeding would have destabilised him, but I think it's the air that led to the failure of resuscitation." So he's really citing air as being the kind of terminal reason for the collapse and death of this infant. So we've got Child E, in which the infant has lost 33% of the blood. What Dr. Evans concocted for that case, again, is utterly laughable, but Dr. Bohin said in court that the blood was nothing to do with the collapse of the infant. Here, we have Dr. Evans saying that the bleeding is not the reason that this infant collapsed and died. So we've established that at the end of this first part of the investigation. So part 2, I'm going to deal with the panel's preview report in which they outline what occurred with this infant and the clinical signs of this baby. So begin with this paragraph here. So Child O was a second triplet born at 33 and 2/7 weeks gestation by in-labour caesarean section at the Countess of Chester Hospital, a district general hospital. So before we go any further, note this is a premature infant. This is a triplet. We've discussed this in great depth with Dr. Martin Pittman. He's told you the risks associated with a triplet, and I think these are the monochorionic triplets as well that exacerbates things even further. Then they were delivered in very close succession of one another. I'm not going to go over all these things again. I just want that to be established at the very start of this process. He weighed 2 kilograms. There are much lighter infants in this court case, but this is still a low birth weight infant. Child O had mild respiratory distress requiring continuous positive airway pressure, type of respiratory support, and oxygen. The triplets were extracted at caesarean section very quickly, a minute apart. Child O's haemoglobin on the day of birth, day 1, was 168 G/L. So we're going to get into that in a second. So as mentioned, premature infants and multiple births have higher baseline risks of complications, including respiratory distress, infection, feeding intolerance, anemia of prematurity, and instability requiring neonatal support. Triplet pregnancy itself does not automatically imply injury, but it's clearly a higher risk obstetric situation. Note the use of the word obstetric. Planned delivery of triplets is commonly earlier than singleton pregnancies because of increasing fetal risks with advancing gestation. Obviously, this is due to a lack of space in the womb, essentially. The fact that the babies were extracted quickly may raise questions about birth trauma or delivery-related events. So I'm going to deal with the haemoglobin on the day of birth being 168 G/L later in the video. I'm not referencing this and not addressing it at this point in time. It's just going to be a section later in the video, so I just want to make that clear now. So on the next day, child O was changed to Optiflow and started on small amounts of feeds. At 36 hours, he was noted to have a rising heart and respiratory rate, temperature instability, and mild abdominal distension. He did not pass meconium until 32 hours of age. Meconium is usually passed within the first 24 hours. So this passage describes a change in clinical status during the first 36 hours of life. A move to Optiflow suggests that the baby's respiratory condition was seen to be improving, allowing a step down from stronger support, in this case CPAP. It could be, though, that the baby's respiratory condition wasn't actually improving and that they inappropriately stepped down from stronger support, when actually they'd missed the signs of deterioration and child O should have continued to receive the higher level of respiratory support. A small feed volume is a cautious trial at this point rather than an assumption that the baby can feed normally. So the rising heart and respiratory rate at 36 hours observed here is an important physiological change. These can be signs that the baby is becoming physiologically stressed. Possible causes include infection such as sepsis, respiratory deterioration, pain or distress, dehydration, metabolic problems, and abdominal pathology. In any neonatal intensive care unit, this should immediately trigger closer assessment. And I would suggest, and the panel states explicitly, that they failed to notice these deteriorating factors. One of the primary reasons for this is that there was a misdiagnosis of the subcapsular hematoma that was not recognised in timely fashion. Temperature instability can be a sign of infection and or worsening illness. The mild abdominal distension can also be considered significant, but Dr. Evans used this to diagnose air via the nasogastric tube, which he has since abandoned. Distension is also symptomatic of several serious conditions, including bowel obstruction. Meconium is the first stool passed by a newborn. Most healthy term babies pass it within the first day, although it's true that timing can vary. Passing meconium at 32 hours is delayed, but it is not automatically pathological. The concern increases when delayed meconium occurs together with abdominal distension, vomiting, poor feeding, and clinical deterioration, several of which were notably present. The signs were there that this infant was deteriorating, but the hospital missed them. This compounds the fact that they misdiagnosed the subcapsular hematoma in the first place, losing valuable time in the process. So then the next morning on day 3, the abdomen of child O was more distended, with visible loops of bowel, and he was uncomfortable after a feed. By afternoon he vomited undigested milk and had high blood lactate, carbon dioxide, bilirubin and acidosis. He was given fluids and antibiotics. At 2:40 in the afternoon he developed a profound desaturation and low heart rate and appeared mottled. His abdomen was very distended. He was intubated and ventilated with high pressures. So it's important to note the pressure here was 28/5. It's going to increase in the next passage. The clinical picture described on day 3 is significant because it represents a rapid deterioration from a gastrointestinal problem into systemic physiological collapse. In a newborn, this combination of progressive abdominal distension, feed intolerance, vomiting, lactic acidosis, respiratory compromise, and bradycardia/desaturation is a major red flag pattern. Unfortunately, because the hospital had misdiagnosed the infant and yet again missed the subtler signs of deterioration, it was too late by the time that they responded. And so we then read that there's a small purpuric discoloration was seen transiently on his right chest during the resuscitation. At approximately 3:50 in the afternoon, he desaturated again and was re-intubated, receiving cardiac massage, adrenaline, bicarbonate and saline infusions. His ventilation pressures were increased to 32/6 in 100% O2. Dopamine was started and needle aspiration of the abdomen was performed. So this passage simply describes a severe cardiorespiratory collapse in a neonate requiring prolonged advanced resuscitation. Key here is the following. Ventilation pressures were increased to 32/6 in 100% oxygen. This is a ventilator setting. The numbers mean 32 being peak inspiratory pressure, the pressure used to push air into the lungs, and 6 being positive end expiratory pressure, pressure maintained at the end of expiration to stop lung collapse. There's also receipt of 100% oxygen, meaning the maximum concentration of oxygen. Increasing pressure suggests that the clinicians were struggling to achieve adequate oxygenation or ventilation, although as we will see later, the way that this infant was ventilated was a clinical error. So we then see an intraosseous, line being inserted because of poor circulation. And then at about 5:45, blood gas showed marked acidosis and a haemoglobin level that had halved. No heart rate was heard. Just a few minutes later, resuscitation was stopped after consultation with parents. Post-mortem shows a ruptured subcapsular hematoma of the liver. So later in the video, I will explain what went wrong with the treatment of child O, and as mentioned, I will address the hemoglobin issue as well. So let's move on to part 3, which are the Brearey liver allegations. Now, I'm sure people are fully familiar with this, described here by the panel as the blind abdominal insertion of a needle during resuscitation, which may have penetrated the right lobe of the liver, causing further injury, noted by the pathologist as parenchymal hematoma and laceration. So, Dr. Richard Taylor mentioned this in December 2024. Seems even longer ago than that, but it was approximately just over 18 months ago now. Dr. Richard Taylor noted this aspiration at McBurney's point that's become infamous, and that it should have been done on the left side, whereas McBurney's point is on the right side. I've shown previously that McBurney's point is on the right side of the abdomen. Anyone can look at that for themselves, so I won't show it again here. Again, I've previously shown there are multiple, countless papers saying that what Dr. Richard Taylor stated there is true. One recent paper, although this dates back a long time, there are many papers, it was known about at the time. It's not that Dr. Brearey wouldn't have known about it. Diagnostic and therapeutic abdominal paracentesis. If ultrasound is not available, then a skin entry site 1/3 of the way along a line drawn from the anterior iliac spine to the umbilicus in the left iliac fossa is an easily identifiable surface landmark. And then you get the key expression that is often used in these papers, contralateral to McBurney's point. So obviously straight across from McBurney's point, essentially, not near McBurney's point. And that's how it should have been done. The other thing to note is that imaging wasn't used, so you can see an example of imaging here. Now, I think I'll just mention that, of course, for the vast majority of human history, imaging wasn't possible and operations had to be done blind, or had to be done just using a person's body in that sense. Now, I'm not knowledgeable enough about medicine to know whether this process was possible before imaging existed. And would have been conducted before imaging existed. I presume it would have been, because Dr. Brearey attempted to do it without imaging on this occasion. Now, as to why he didn't use imaging, most people, certainly medically qualified people, view this as quite a significant blunder, and there does appear to be very little explanation for it. We've tried to find a possible explanation. We've tried to understand what Dr. Brearey was thinking. Michelle Warden suggested perhaps he just panicked. Who knows? But the fact is he should have used imaging, and that was a major mistake. And fundamentally, that was the reason that he made this terrible error, apart from the procedural aspect of it. The procedural aspect of it was wrong. He used the wrong part of the abdomen. But he still could have avoided this laceration and this drawing of blood, which are acknowledged. It would have been more likely that he could have got away with the wrong procedure had he used imaging. For some reason, he did it blind, and that is an obvious mistake. Now, there have been some suggestions I've seen on the ever-reliable platform of X or Twitter that somehow Dr. Brearey is going to be able to sue people for saying things about him that are untrue. So firstly, in the documents from the Thirlwell inquiry, it's noted here that Child O's abdomen was noted to be significantly distended. Dr. Brearey inserted an intravenous cannula line to his McBurney's point to try and decompress the abdomen. A small amount of blood was obtained, which was sent for a blood culture. So that's the first thing. Secondly, this is referenced here in court, where it's the question here from the barrister is, you referred next to the insertion of Dr. Brearey of an intravenous cannula at McBurney's point. That's correct. And the fact that he obtained blood from that, he did. And then the person goes on to say, but as he said yesterday, only a small amount of blood. I wouldn't like people to suspect there was a huge amount of blood there. And then finally, he told us that he only obtained a small amount of blood. So I would suggest to you, before we assess this any further, that Dr. Brearey said, I only obtained a small amount of blood. I would suggest he wasn't necessarily the most objective witness of this process at this point. So I'd say that the amount of blood is not entirely established there. However, let's just assume for the sake of argument that this is correct and there was a small amount of blood. No one is saying that this is decisive with regards to the amount of blood. What is being said is that it exacerbated the issue. But anyway, I believe this is Dr. Bohin speaking in court, and Dr. Bohin raised the cannula issue in her notes as well. So the idea that Dr. Brearey is going to be able to take some form of legal action when it was discussed explicitly in court and is not contested by anyone seems pretty fanciful, to say the least. And then, as is outlined in my book by Dr. Shu Lee, the process was the wrong thing to do anyway. There was no need. In fact, it was detrimental to put a needle into the abdomen. They should have attempted to suck the air out with a nasogastric tube. Decompressing gaseous distension of the stomach with a needle was a mistake, and particularly to do that without ultrasound guidance was definitely a mistake, but it was the wrong procedure in the first place. So if we sum all of this up, as mentioned just now, the aspiration was the wrong process in the first place. This followed a critical misdiagnosis of a subcapsular hematoma. The insertion was performed blind when imaging should have been used. An incorrect methodology was used. The wrong side of the abdomen was utilised. Dr. Brearey punctured the liver and drew blood, likely exacerbating existing injury. This cannot be denied as the procedure is contained in Thirlwell documents. The incident was discussed in court, and even Dr. Brearey conceded during court proceedings that this had occurred. Part 4 of this whole picture is that there are multiple problems with the supposed blunt trauma. Now, there are many issues with the allegations of the prosecution, but there are essentially two overarching problems. The first problem is that the alleged mechanism is preposterous. So it is alleged that the liver damage was caused by some sort of trauma. In support of this, Evans suggested that Lucy Letby physically struck the infant. Perhaps not unsurprisingly, there is no evidence for this at all, and it frankly appears to be an extraordinary and ludicrous assertion. I just want to reiterate once again that no one saw Lucy Letby do anything suspicious at any time on this unit, and also no one suspected anything. There's no reason whatsoever to believe that Lucy had done anything wrong, but now Dr. Evans has suggested that Lucy Letby has essentially punched a young baby, a very small infant, in the stomach, and this has caused some sort of trauma to the liver. Just absolute rubbish, essentially. It appears the sole reason this has been suggested is that there has to be some mechanism cited which involves malfeasance from Lucy Letby. In the case of child O, it is clear, mind-numbingly obvious in fact, that the bleeding and subcapsular hematoma is critical. The air injection allegation appears tacked on witlessly because air has been cited in other cases, and also because this makes it appear to be a more coordinated attack from Lucy. Obviously, I've discussed the air earlier in this video. The idea that air was critical in the collapse of this infant is entirely laughable. There is no evidence, indeed, for the injection of air, and there is no evidence that Lucy Letby struck child O in the liver, as is alleged. These are both allegations that are completely without foundation. I would suggest to you as well that they are both utterly preposterous. This is similar to the allegation made in the case of child E, that Lucy Letby used a nasogastric tube, not a nasogastric tube, an indeterminate object, to somehow create bleeding in this infant when the child obviously collapsed due to gastrointestinal hemorrhage. Again, this was just absolutely speculative. It can't possibly be described as a diagnosis. If this occurred in a hospital, as I've said previously, there is just no way that anyone would make these allegations or suggestions or make these citations as being the cause of collapse and death, because they would be viewed as laughable. It could be potentially career-ending, even. There are also question marks regarding whether Lucy Letby was even on duty when the supposed attack occurred, although considering that the mechanism is completely fabricated in the first place, this doesn't really seem to matter. And then the second problem, that's a pretty big problem in and of itself, obviously. The second problem is that blunt trauma is medically untenable. Blunt direct trauma to the right abdomen or chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in a liver protected by the lower chest wall, let alone could they be created by Lucy Letby supposedly striking the infant in the liver, and she has to do this in such a manner that no one sees anything and no one suspects anything, and there's no reports of the infant suddenly crying out when Lucy starts to punch the infant supposedly. It's rubbish. It's total rubbish. And in my book, I've quoted this thing. This is Dr. Shu Lee noting that it's the subcapsular hematoma and the injuries cannot be caused by direct abdominal trauma. They're the result of traction or shear forces applied to the thin, fragile liver capsules through the hepatic ligaments, usually during delivery. And this child, who was the second of triplets, had an extremely rapid delivery, which is a well-recognised cause of birth injury. As mentioned earlier, the triplets were delivered very quickly after one another, prematurely. I'm going to go over a little bit more of that towards the conclusion of this video. So, part 5 of this picture are the obstetric issues that were discussed in the recent BBC documentary. So this was a really important contribution. Not only the fact that we heard that other parents, other mothers that were on the maternity unit at the County Chester Hospital in a similar time period to when Lucy Letby was working there, not only did they receive poor care, but there were these major issues that were revealed in relation to child O with regard to the disclosure of documents and obstetric issues that would appear to be central to the collapse of this infant. And not only were they never discussed in court and never revealed to the jury, but Dr. Evans never even made any effort to obtain the maternity or obstetric notes, which are very likely, overwhelmingly likely to be absolutely critical in the case of child O. So the disclosure issues here are really important because it was stated in the BBC documentary that this had not been disclosed to the defence, the fact that the prosecution had obtained the obstetric and maternity documents. Dr. Evans had made no effort to look at them. And then this had never been disclosed to the defence, and the documents had not been made available to the defence, despite the fact that they had been requested by the defence. And then we heard from Professor Bennett, who stated, as you've heard this now, I've heard this personally from 3 separate obstetricians, you've heard it from Dr. Martin Pittman on this channel. The mother describes a huge spray of blood having shot up from where the delivery was taking place and going over herself and her partner onto the wall behind in the operating theatre. So this suggests that the obstetrician probably cut through a blood vessel, and therefore they felt the need to deliver the babies as quickly as possible, because you can't stop the bleeding until the babies in the placenta have been delivered. So it's important to emphasise at this point that we don't even know whether Dr. Evans was even aware of the blood splattering over the wall, because he made no effort to seek out the maternity or obstetric notes, and we know that there was scant information in the neonatal notes. He has conceded this. So we have no idea whether or not Dr. Evans is even aware of this blood splattering that is extremely critical. Should also be briefly mentioned that this was the case in which Dr. Evans decided immediately in the Cheshire Police Station in Blacon in, we believe to be June 2017, that just in a matter of minutes, there's definitely been inflicted harm here. Give me all the notes and I'll decide what's happened. So part 6 of this is the haemoglobin issue. So the haemoglobin level of this infant didn't drop immediately. There was a delay in the falling of the haemoglobin, and this has been rather witlessly suggested on Twitter by the Idiot Brigade to be of some significance. It's not of any significance at all. There's a very simple explanation for it. But I'm going to go over that in some depth, seeing as this has been raised as a point, obviously by people who know nothing. So, child O collapsed because the subcapsular hematoma ruptured, causing acute major hemorrhage into the peritoneal cavity, sufficient to cause a near halving of the hemoglobin level. Bleeding into a subcapsular hematoma is characteristically initially slow because it is contained by the pressure of the enveloping liver capsule. In these early stages, the clinical signs are insidious and difficult to recognise, which is why they didn't recognise them, why they misdiagnosed the whole thing, why they made countless mistakes, and why this infant sadly died when it was potentially avoidable. High pressure ventilation decreased venous return to the heart and contributed to liver congestion. The slow deterioration is then characteristically followed by acute collapse when the capsule ruptures, releasing free blood into the peritoneal cavity. So the explanation was already there in the preview report, but I'm going to explain all of these mechanisms in some depth. So firstly, the mechanism described here is entirely consistent with the classical description and presentation of a neonatal subcapsular hematoma. One of the distinctive features of this injury is precisely that the hemorrhage and the haemoglobin fall are often delayed, producing a characteristic two-stage clinical course. So I'm going to go over all of these aspects quite thoroughly. Question 1 is, why is the bleeding initially delayed? A subcapsular hematoma forms when small hepatic vessels tear, but the liver capsule, the Glisson's capsule, remains intact. Instead of blood escaping freely into the abdomen, it accumulates between the liver tissue and the capsule, creating a contained hematoma. The capsule behaves in a manner akin to a tight elastic envelope. Bleeding begins immediately after the injury, but the accumulating blood rapidly generates pressure inside the confined space. That pressure compresses the injured vessels, which tends to reduce further bleeding, a temporary tamponade effect. As a result of this, blood loss is relatively slow. The infant may initially appear reasonably stable. The hematoma enlarges progressively over many hours or even several days. This is why many reviews describe the early phase as insidious, with only subtle features such as mild abdominal distension, pallor, tachycardia, poor feeding, increasing metabolic acidosis, and progressive anemia. Of course, several of these things were observed in this infant. Secondly, why does the capsule suddenly rupture? As blood continues to collect, the capsule stretches, wall tension rises, analogous to inflating a balloon, and eventually the tensile strength of the capsule is exceeded. Once this occurs, the containment is lost, blood suddenly pours into the peritoneal cavity, the tamponade effect disappears, and previously compressed vessels can bleed much more freely. The result is the classic sudden transition from compensated internal bleeding to catastrophic hemoperitoneum with hemorrhagic shock. This silent phase followed by sudden collapse is repeatedly emphasized in neonatal literature. So the third aspect of this is, why can positive pressure ventilation make matters worse? So we're going to discuss the fact that the infant was ventilated at the wrong pressure. We've discussed this a little bit already, which exacerbated the issue. High airway pressures can contribute in several ways. First, positive pressure ventilation increases intrathoracic pressure. This reduces venous return to the heart, raises central venous pressure, and impedes venous drainage from the liver. The liver therefore becomes more congested. Congested hepatic veins contain more blood under higher pressure, meaning that if a capsular tear already exists, bleeding may continue, the hematoma may enlarge more rapidly, and rupture may occur sooner. In addition, severe illness requiring high ventilator pressures often reflect profound physiological stress, acidosis, and impaired coagulation, all of which may worsen bleeding. Again, we know this is present, we know this occurred, and we know there was high ventilator pressure. So fourthly, why is the haemoglobin fall delayed? Immediately after an acute hemorrhage, haemoglobin concentration often changes very little, even when a large volume of blood has been lost. The reason is straightforward. Whole blood contains red cells and plasma in fixed proportions. If 100 milliliters of whole blood is lost, then both plasma and red cells are lost together. Therefore, the concentration may initially remain close to normal. Now, long before we go on to the fifth part of this, I just want to emphasize the following. This is complex for me and may also be complicated for some viewers. However, for those in the panel, this is Neonatology 101. It's as plain as the nose on their face. When I spoke with Dr. Shu Lee, he explained to me that on a more experienced unit, certainly a level 3 unit, and these triplets should have been treated on a tertiary unit, they would have been thinking of a subcapsular hematoma immediately. This unit failed to diagnose correctly because there was a lack of leadership and general competence. We know that only too well from what we've heard now in the BBC documentary. Child O was another potentially avoidable death had there been timely diagnosis and appropriate intervention. The way that the infant was treated, unfortunately, sadly, he had no chance whatsoever. Point 5. Why does haemoglobin later fall dramatically? Over the following hours, several things happen simultaneously. The body attempts to restore circulating volume by moving fluid from the tissues into the bloodstream, administering intravenous fluids, and giving saline during resuscitation. These fluids contain no red cells. They therefore dilute the remaining circulating blood. So although the total red cell mass has already been reduced by hemorrhage, the plasma volume gradually increases. The consequence is falling haemoglobin concentration, falling hematocrit, and progressively more obvious anemia. This is why clinicians often say acute blood loss occurs first, the haemoglobin fall follows later. The value measured in the case of child O, therefore, reflects not only how much blood has been lost, but also how much plasma replacement, either physiological or intravenous, has subsequently occurred. And point 6, how does this fit with a ruptured subcapsular hematoma? The sequence is therefore as follows. Birth injury causes tearing of small hepatic vessels, blood accumulates beneath the liver capsule, the capsule temporarily contains the hemorrhage, limiting blood loss, clinical signs are subtle while the hematoma enlarges, hemoglobin may initially remain relatively preserved despite ongoing bleeding, tissue fluid shifts and intravenous fluids progressively dilute the circulation, the capsule finally ruptures, massive hemoperitoneum develops, rapid hypovolemic shock occurs, hemoglobin then falls markedly, reflecting both the accumulated blood loss and subsequent hemodilution. This two-stage progression and initially contained subcapsular bleed, followed by sudden rupture into the peritoneal cavity with delayed recognition of anemia, is regarded as the classic presentation of neonatal subcapsular liver hematoma in the medical literature. So, in the extremely unlikely event that Professor Bennett, someone of his status, qualifications, knowledge, standing, intelligence, credentials, etc., if for some unknown reason he decided to interact with the witless Twitterati, then he would obviously give a much better explanation than me. But that essentially explains the haemoglobin issue. Finally, I just want to mention this that was provided to me by Dr. Martin Pittman. This is page 97. This refers to a critical resuscitation sheet for child O, which has become a focal point for controversy regarding medical evidence, been referenced in Private Eye multiple times. According to analysis by medical experts, the document records a significant sudden drop in the baby's haemoglobin levels following the aforementioned needle insertion near the liver by Dr. Stephen Brearey. Resuscitation sheets on page 97 reportedly show the dramatic drop in haemoglobin occurring after the procedure, but Dr. Brearey allegedly documented the fall in haemoglobin as if it happened before the needle insertion. This is missing from the initial trial. This was never seen by anyone, raising questions about whether it was accidentally missed or deliberately omitted from the court bundles. While prosecution experts argued child O's liver injuries were the result of blunt force trauma, critics and alternative reviewers suggest the document provides contemporaneous evidence that the medical procedure itself may have inadvertently caused the drop in haemoglobin. I think it's not that this entirely caused the drop, but it can, as is rightly stated, be a contributing factor to exacerbating the existing condition. So that brings us to the final part, what actually happened with child O. So child O collapsed because the subcapsular hematoma ruptured, causing acute major hemorrhage into the peritoneal cavity sufficient to cause a near halving of the hemoglobin level. Subcapsular liver hematoma is the result of traction or shear forces applied to the thin, fragile liver capsule through the hepatic ligaments. In child O, this was highly likely the result of the extremely rapid delivery, which is a well-recognised cause of birth injury. Bleeding into a subcapsular hematoma is characteristically initially slow because it is contained by the pressure of the enveloping liver capsule. In these early stages, the clinical signs are insidious and difficult to recognise. High-pressure ventilation decreased venous return to the heart and contributed to liver congestion. It should be noted that the infant should not have been ventilated at this pressure setting, and that was yet another medical error. The slow deterioration is then characteristically followed by acute collapse when the capsule ruptures, releasing free blood into the peritoneal cavity. The significance of the rising heart rate and the falling pH before the terminal collapse were not recognised. The blind abdominal insertion of a needle during resuscitation may have penetrated the right lobe of the liver, causing further injury, noted by the pathologist as parenchymal hematoma and laceration. Blunt direct trauma to the right abdomen or chest is implausible because it is very difficult to generate the kind of forces required to produce the observed injuries in a liver protected by the lower chest wall. The gaseous distension of the intestinal tract was likely due to air swallowing and insufflation during non-invasive respiratory support. The suggestion of injection of air into the circulation is conjecture. I would suggest it's generous to describe it as conjecture. Child O died from a subcapsular liver hematoma caused by traumatic delivery resulting in hemorrhage into the peritoneal cavity and profound shock, and this was simply not recognised ante-mortem. So if we look at this sequence of events, very rapid delivery injures the fragile neonatal liver, a small liver bleed develops, blood collects under the liver capsule, the baby initially appears relatively stable because the bleeding is contained, warning signs appear, there's a rising heart rate, worsening blood gases, and increasing instability. The capsule eventually ruptures, blood floods the abdomen, the baby rapidly loses circulating blood volume, and the baby collapses and dies from hemorrhagic shock. Now, I want you to compare that sequence of events that has been put together by the international panel with the version of Dr. Dewi Evans. Lucy Letby punches the child in the liver. This somehow creates trauma in the liver. The subcapsular haematoma is discounted as the cause of collapse. The blood loss is not cited as the cause of collapse. Lucy Letby injects air via the nasogastric tube. Oh no, Lucy Letby injects air venously to create an air embolism, and it is the air embolism that ultimately kills the infant. Now, I want you to look at those two things, look at those two sequences of events next to each other, and ask yourself the question, which one of these is more credible? Is it the one that's been put together by neonatologists of world-class level for which there is extensive neonatal literature support, or is it the one that's been essentially fabricated by Dr. Evans out of nothing with absolutely no evidential support whatsoever? So this is why Dr. Gordon Caldwell has recently stated on Twitter, the theory Letby punched the liver causing severe trauma is a nonsense. There was a subcapsular haematoma in the liver, common after rapid delivery in premature babies. These haematoma rupture spontaneously, and treatment is transfusion, not a doctor needling the abdomen. It's also important to mention or reiterate that a major failing in this case was the initial misdiagnosis. This infant could have been saved with appropriate diagnosis. So I just want to finally mention I didn't give a very good explanation regarding triplet pregnancies and why they occur prematurely. So it's not really because there's not enough room, it's because the mechanical stress of carrying a very large pregnancy activates molecular pathways that make the uterus progressively behave as if it is approaching term. So the mechanism for this is explained here, and someone who's qualified in obstetrics will give a much better explanation than I possibly could. I might ask this question to Martin Pittman at some point, and he will no doubt explain the whole thing. Now, this is the Court of Appeal verdict and judgment in relation to the initial trial, and as you can see, the method of supposed murder for this infant was inflicted in injury to the liver and air embolus, which is farcical. So I tweeted about this the other day, and I said the following. There is a very simple explanation for the attached comment related to haemoglobin, which can easily be identified by using Google. Frankly, the comment is very obviously redundant if you have any understanding of the case. It's also important to note that the prosecution case for Child O has no evidential support, is completely preposterous, and part of it has even been jettisoned by the person who proposed it. The court did not hear credible expert evidence on this case, which is why they drew an erroneous conclusion. As we sit here today, we know that the mechanism of supposed malfeasance for this infant is utterly untenable. It is now incumbent on the system to facilitate credible expert evidence being heard. This must include all medical documentation being made available to the defence, as there appears to be serious disclosure issues in this area. I have also attached an extract from the court transcript of Wednesday the 15th of March 2023. I have encountered bizarre claims that the cannula insertion incident never happened. It was, in fact, discussed in court. As mentioned in the panel preview report, and no doubt discussed in considerable detail in the submitted report, this unintended laceration can be a contributing factor to the clinical signs and decline of this infant. I've already discussed all of this in my book. In the next few days, I will release a new video on Child O, which is, of course, this video. So in conclusion, we have learned the following during this video. The prosecution asked the jury to believe that Lucy Letby deliberately attacked Child O by inflicting blunt trauma to the liver and injecting air, first into the stomach via a nasogastric tube, and later, after the trial, effectively changing the allegation to air entering the venous circulation. These are undoubtedly extraordinary allegations, and they should require extraordinary evidence. Yet when we examine the medical literature, when we examine the chronology of this infant's deterioration, when we examine the pathology findings, and when we examine what is now suspected about the obstetric history and the delivery itself, a very different picture emerges. Every significant clinical feature can be explained by a recognised sequence of natural events: traumatic delivery causing a subcapsular liver haematoma, initially slow contained bleeding beneath the liver capsule, progressive physiological deterioration that was unfortunately not recognised, eventual rupture of the capsule with catastrophic hemorrhage, and a series of medical interventions, some of which have exacerbated an already critical situation. not to mention being the wrong medical interventions in the first place. These are all medically known, supported, and evidenced phenomena. This explanation does not require speculation. It does not require inventing mechanisms that have little or no support in neonatal medicine. It does not require assuming that a neonatal nurse somehow delivered sufficient blunt force to damage a protected liver without anyone seeing anything, hearing anything, or indeed suspecting anything. Nor does it require unsupported theories of deliberate air injection that have shifted over time and, in important respects, have already been abandoned. Perhaps most importantly, this case illustrates why complete disclosure and proper expert evidence are absolutely essential in criminal proceedings, particularly those involving highly specialised medicine. If relevant obstetric records were not properly considered, if significant aspects of the delivery were not presented to the jury, and if internationally recognised neonatal experts now offer a fundamentally different explanation, then those matters must be examined openly and objectively. This is not only a matter of justice for Lucy Letby, it really speaks to the credibility of the entire criminal justice system. Ultimately, the conclusions reached at trial are not even remotely scientifically or medically sustainable in light of the available evidence, and there is further evidence that is yet to be made available. Justice depends on reliable evidence, not speculation. Medicine advances by questioning assumptions, testing hypotheses, and changing conclusions when better evidence becomes available. The legal system should be no different. As we sit here today, the prosecution's explanation for child O is untenable. The alternative account is coherent, medically supported, and consistent with the known physiology of neonatal subcapsular liver hematoma, the likely obstetric circumstances, and the infant's clinical course. The interests of natural justice require for this evidence to be heard, and heard rapidly. If you have enjoyed this video, the case of child O, and indeed the whole picture surrounding the conviction of Lucy Letby, is discussed in considerably more depth in my recently published book, Reasonable Doubt, examining the conviction of Lucy Letby. This book is available from Amazon, Waterstones, many bookshops, and direct from the publisher, Cinto Press. Thank you for watching, and I look forward to reading your comments and questions, as always.